Good afternoon, everyone. Is my screen visible? Hello,
Yes, ma'am.
Vishwas. I can't hear. Sorry. Is my screen visible?
Yes, ma'am.
Okay. So I think there is a little bit of a twist today in presentation. I have given this QR code and it belongs to Slido. So there will be some intermittent. We try to make this session a little bit interactive so that nobody sleeps. You can all scan this QR code and let me know whether it's working. Can somebody scan and tell me whether it's working? You will come to a Slido site and there you will be seeing a registration or registration as in you will just see some polls. Are you able to? Hello?
No, no.
Yeah.
It's not working. I mean, I'm trying.
Okay. No, but are you able to go to that site? Are we questions when they come, then it will open. But you could
Okay.
see that there is cytokine release syndrome written.
I'll try again. Wait.
So just scan it and then click on that thing, or you can go to this. You can go to this site link also. But the scanning is working. At least I tried on my phone. It's working. Mm. Somebody in the this thing come to my room. When Gupte,
Yeah, sure.
it's working. Please confirm.
No, ma'am, it's not working. Leica is coming.
Yes, come. So this is the first question. Now you will be able to see the first one.
Yes, yes, ma'am. What is the
Able
most
to
common
see.
initial symptom?
Mute yourself. So this is the one. Yeah, yeah. So you have to attempt now. Okay, good. So please attempt, then we will go ahead. Yes, so there only two people have attempted. Please try. There are 13 people in this. Do you want me to show this? You can scan this QR code or go to Slido and put this number. Let's make it interactive. So I'm sorry to spend time on this, but it'll be fun. It'll be nice learning. Okay, so I'll move ahead. So, what is CRS? Just 1 minute. Whoever is there? Priyanka's iPhone, please mute. Priyanka's iPhone, please mute yourself. Yeah, yeah. So, 1 minute. What is cytokine release syndrome? Cytokine release syndrome, basically, it is a generalized immune activation which is correlating with the CAR T expansion. So whenever we are doing the immunotherapy or CAR T cell therapy, there is immune activation, and this activation leads to a cascade of reactions, which is associated with elevations of marked serum inflammatory markers and cytokines. And these, we will see the whole mechanism of action, a mechanism pathophysiology of how this cytokine release syndrome happens. So what are the first clinical signs of CRS? It's fever, myalgias, and fatigue. Fever many a times is low grade. Majority of the cases it's low grade, but it can escalate over the next few days when the patient is admitted, and the temperatures can go up to 105 degrees, which is what is commonly observed. CRS can progress to life-threatening disorder like a vasodilatory shock or capillary leak, hypoxia, or end-organ dysfunction. It usually occurs within 1 to 14 days after the infusion. So that is the time period which we usually keep the patient admitted. And depending on the product, clinical trial design, and the population being treated, there have been various studies which have shown that the incidence of CRS and the severity of the CRS varies from population to population, varies from product to product, and it varies from various clinical trial designs. Now, the duration is again whether we are intervening or we are not intervening, what are the grade of CRS that we are dealing with. So, if we are dependent on the intervention, usually the CRS resolves within 2 to 3 weeks of CAR T infusion. So, any event which is happening after 3 weeks or after 4 weeks of CAR T infusion is probably not CRS, and we should think of something else. So, what are the laboratory markers which are pathognomonic of this CRS? It is C-reactive protein, that is CRP, which we commonly do. It's ferritin, and there are certain other markers like interleukin 6. We also have the facility to do interferon gamma and various other markers like soluble CD25 as well. So, cytokine profiles, they correlate with the clinical syndrome of CRS. Means if the cytokine levels are high, you can expect that the patient will have a more severe CRS. So, depending upon the level of the cytokines, the severity of the CRS can be judged. So, we also need to differentiate CRS from overlapping diseases like macrophage activation syndrome or HLH. So many a times it may be difficult, but we should try and attempt every possible way to differentiate because the management differs slightly. My future lectures, so these are series of lectures which we have planned. So CRS is the first in that series. I'll be covering macrophage activation and HLH in future lectures. So this is again an overview, what we just saw. What are the symptoms? Fever is the most common. It can also have hypotension, hypoxia. Usual onset is day 1 to day 9 after CAR T infusion. Majority of the cases happen between 5 to 11 days. Various cytokines that are elevated are all these interleukin 6, interferon gamma, TNF alpha. Then it depends upon the patient characteristics and the characteristic of the CAR T product also. Management, we probably will be covering today. I won't be able to finish off management because there is quite a lot to discuss about the pathogenesis of CRS. So let's go ahead. So this slide, what we can see basically, I'll try to simplify it and try to make you all understand because we have some nursing stuff as well here. So these are the diseases: ALL, NHL, mantle cell, multiple myeloma, various studies that have been conducted over the years. What you can see here is the CRS was when the studies were done earlier in the earlier settings. Like as we have advanced, the incidence of CRS or the incidence of severe CRS have reduced earlier because probably we have learned how to manage it better now. With the experience, we know how to manage CRS better. So the recent more studies do not report as many severe CRS as it was earlier. So the severity was here 27, 30, even one third of the patients were suffering from CRS in when the clinical trials for CAR-T started. Same is across. So also you can see the difference. In non-Hodgkin's lymphoma, the percentage of CRS is lesser as compared to that in acute lymphoblastic leukemia. So ALL is more aggressive of a disease, and the amount of CRS, the severity of CRS that we are seeing, please mute. So the amount of CRS which we are seeing in ALL is also more in ALL as compared to NHL, or for that matter, multiple myeloma. So now moving to the next one. So what is the pathogenesis? So CAR T cell activation, and there is something you must have heard of, a term called apoptosis. Apoptosis is the cell death. Cell death, one of the type of cell death is apoptosis. But what happens in CRS is pyroptosis, not exactly apoptosis. And pyroptosis is of the target cells is the root factor for pathogenesis of CAR T. So let's look at what happens. Now this is the CAR T cell. This is what is the recognizing part of the CAR-T. Asmita, please mute yourself. And so what is happening is when the CAR-T cell is coming in contact with this tumor cell, it induces something called as pyroptosis. Now, CAR-T cells, it secretes perforin, it secretes granzyme, it secretes tumor necrosis factor alpha, and interferon gamma. So then we'll come back to this slide. I'll just explain this part here. Now, perforin, as the name suggests, it perforates the cell membrane, and it introduces these enzymes inside. Okay, so granzyme A and granzyme B. These are the two important enzymes which are responsible for causing pyroptosis. So there are various mechanisms by which these granzyme A and B act through the caspase pathway and directly also. So, and this results in pyroptosis. Now, what is pyroptosis? Pyroptosis is a type of programmed cell death that differs from apoptosis. It is characterized by cell swelling, lysis, and subsequent cell content and pro-inflammatory factor release. So, whenever this cell dies, it swells up and it releases further inflammatory content. So, even the tumor cell which is dying is releasing those pro-inflammatory factors, and that is what is causing CRS. So, go back here now. So what else happens? Now, this tumor cell is also having a CD40 ligand. CD40 is present on this macrophage. Macrophage are the normal, what we call scavengers in the blood. So when this ligand binds, then what happens? It releases all these factors again. It releases DAMPs. It causes endothelial cell activation, vascular permeability increases, there is leakage from the endothelium, there is additional interleukin 6 which is produced, there is other cytokines, and there is coagulopathy. So there is a lot of interleukin 6 which is produced. So interleukin 6 is sort of the end it is end marker, as in it is the one which is mediating most of these side effects, most of these effects. So there are receptors of interleukin 6 on the endothelial cells. So you can see interleukin 6 is a pro-inflammatory marker, and there are receptors for binding to the interleukin 6. So when this interleukin 6 binds to this endothelium, there is increase in the vascular permeability, as in these cells which are bound together, they are stuck to each other, they separate, and then they can allow whatever is there in the blood vessels to come out. So there can be capillary leak, there can be swelling, there can be edema, and all these inflammatory markers, they are already in the blood. So all these mechanisms lead to the various manifestations like fever, hypoxia, hypotension, and so on. So let's move on to this activated macrophage. Now, when the macrophage had got activated, what did it do? So this is like toll-like receptors. These are called toll-like receptors, which are present. So various macrophage can be activated by whom? It can be activated by DAMPs, which are damage-associated molecular patterns. It can be activated by high mobility group box 1, ATP, dsDNA, and catecholamines. All of these can activate through the macrophages. These macrophages can be activated. And when they are activated, they further lead to secretion. So you can imagine it is like a vicious cycle. One thing leads to another. If you have read what is vicious cycle, positive feedback loop. So whatever is getting killed is secreting some pro-inflammatory markers, whether it is a tumor or whether it is the T cells themselves or CAR T cells, or whether they are the macrophages. Whatever is getting in contact with the CAR T, it starts secreting the inflammatory markers, and that's what leads to cytokine release syndrome. So how does interleukin 6 do its activity? Interleukin 6 is released by monocytes macrophages that we saw. Then there is increase in interleukin 6. All these factors, they are released. Now what happens? We saw to the endothelium in that cartoon. And now these activated endothelial cells, even when these endothelial cells are also getting activated. So you can imagine everything is active. So interleukin 6, they are also secreting. Activated endothelial cells also secrete interleukin 6 and other markers like VEGF, MCP1, and plasminogen activator inhibitor PAI1. So this leads to a positive loop. That this is what I was telling, positive feedback mechanism, and that causes amplified inflammatory response. So when there can be coagulopathy also associated with CRS because of the tissue factors, factor 7A and factor 10A. Now, we can divide the CRS into two parts, local CRS and systemic CRS. Local CRS is what we are aiming at. Systemic CRS is what we are getting along as a bystander effect of the local CRS, because it is uncontrolled. Local CRS, when becomes uncontrolled, leads to systemic CRS, and then that systemic CRS, if it is not curtailed with the help of medications, can lead to multi-organ dysfunction in the maximum, which we call as grade 3, grade 4 CRS. But what we want is this kind of a process, which is actually responsible for killing the tumor cell. So now let's do the poll again. Try, please. It worked last time when I did it for another presentation of mine. Please scan and just vote. I'll keep it for maybe 30 seconds. Is it not working? Okay, it's okay. It's only one vote. Abhi, then I'll give this quiz to others, everyone. If fine. So, which factor? Yes, high tumor burden is probably one of the most important factor, which can probably increase the likelihood of severe CRS. So, which are the factors which increase the likelihood of having a severe CRS? So, if the patient has a high tumor burden at a baseline, what do you mean by that? So, if the patient has a full-blown disease, in acute leukemia, we have a cutoff. So usually 5% is also considered. If the patient is having lesser the disease, lesser is the chance of CRS. At the time of CAR T infusion, if the patient has more than 5% of blasts in acute lymphoblastic leukemia, or if a patient has bulky disease in cases of DLBCL, or in cases in any other lymphomas, then those patients, if they are given at this stage of the disease, then they will have higher CRS. So what do we do? Once we have collected the stem cells, we give something called as a bridging therapy to curtail this high tumor burden. Now, if there is pre-infusion inflammatory markers are raised, how can they be raised? How will the pre-infusion inflammatory markers be raised if there is any infection? Patient has any infection, or patient has any other comorbidities. CRP is high, interleukin 6 is high, so they are already elevated. So there is more risk of these patients developing higher grade of severe CRS, any advanced comorbidities. And it has been seen that pediatric patients who are receiving CD19 CAR T for ALL are more at risk of developing higher CRS than adult patients with lymphoma. Then there are certain lymphoma subtypes like primary mediastinal B-cell lymphoma, which have demonstrated an elevated CRS risk in some studies. How does the construct of the CAR T effect on the CRS? So there is something called as a co-stimulatory domain within the CAR. In those, if it is derived from CD28 versus 41141BB, there can be, and depending upon the T cell expansion kinetics, there can be difference in the CRS profile. So CAR T cells which are incorporating the CD28 domain are often associated with more rapid expansion and higher incidence of acute severe adverse events, whereas 41BB domain is expand more slowly and persistently with lower peak proliferation and have gradual and less toxic immune response. Now, the dose of the CAR T also matters. So, optimal clinical efficacy was seen for CD19 CAR T was seen in 50 to 100 million cells. And in BCMA CAR T, it's usually a higher dose, from 150 million to 450 million cells have been used in BCMA CAR T. So, higher the dose, higher is the risk of CRS. So, but also there is this thing that once it doesn't mean that we increase the dose and the efficacy of the CAR T keeps on increasing. No. So the dose escalation with the increasing objective response rate, that there is a threshold which is reached, beyond which only the side effects will increase and not the overall response rate. So these are the usual CAR T cell dosages which have been many a times administered in the patients. So we can see that in children, we usually minimize up to 0.2 to 5 million cells per kg body weight. And in multiple myeloma, the cell dose is very high. So when there is reinfusion of higher dose of CAR T, sometimes we give a reinfusion of CAR T that can be associated with higher anti-tumor efficacy, but again, that is associated with subsequent increase in incidence and severity of the CRS. Now, this was a study from MSKCC, Memorial Sloan Kettering, where they showed that patients with higher disease burden, that is more than 5% bone marrow blasts, with a lower dose of cells, what did they do? Because the disease burden was high, they started initially with a lower cell dose. As compared to 3 million, they gave only 1 million in patients with a higher disease burden to reduce the CRS related toxicity. So the total planned CAR T can be infused in fractionated dose also if you are anticipating higher CRS related toxicity. Also, there is some studies which are seeing that if we optimize the CAR T, because we are seeing the T cells. So if we optimize the ratio of CD4, CD8 cells in 1:1 ratio, this is appearing that this product is better toxicity, has better toxicity profile than the product which has more of CD4, because CD4 has been attributed to be the one which is responsible for driving the cytokine release syndrome during CAR T cell therapy. So this is another study from France, which has shown the similar findings in mouse models. So where interpatient variability in CAR T cell subset contributes to CRS, like CD4 CAR T are the main drivers of CRS. So if we optimize the ratio of CD4 CD8 cells, then maybe we can mitigate the CRS in a better way. Now, even lymphodepletion regimens that we use for the patients as a preparation regimen for the patients to receive CAR T can affect the CRS incidence. So, patients who are getting fludarabine and cyclophosphamide as compared to only cyclophosphamide have higher risk of severity of CRS. So, this is another one. Please attempt. Okay. So I think, yeah, dosage of CAR T is one of the most, this is a poll actually, but this is depending upon what your experience has been, that which is the most concerning. But yes, dosage of CAR T is one of the most important and most concerning finding for determining CRS. So what are the risk factors? We'll just see in this. Risk factors and predictors for CRS are higher disease burden, higher infusional dose, fludarabine containing lymphodepletion, concurrent infectious illnesses, and early cytokine elevations. How can we prevent this? We can cyto-reduce the disease. Before starting CAR T, let's get it to the minimal possible. And inverse the dose adjustment by disease burden, that we saw that if the disease burden is very high, then you reduce and fractionate the CAR T dose, fractionated dose schemes. And we can also consider prophylactic anti-cytokine therapy if we are anticipating a higher grade of CRS. Now, what are the grades of CRS? So initially there was a lot of confusion. There were multiple systems, and the three main important systems were CTCAE, Lee criteria, and Penn criteria. But then came the consensus by the ASTCT group, and they simplified it to form this consensus grading, divides the CRS into 4 grades, where the temperature is the foremost. It has to be more than normal. But depending upon whether the patient has hypotension or hypoxia, which is manageable with or without vasopressors, we divide it into grade 2 or 3. Patient is requiring oxygen only by nasal cannula or blow by. If the patient starts requiring one vasopressor without vasopressin, as in most commonly that we use is noradrenaline. So if the patient is only on one inotropic support or requiring high flow nasal cannula or face mask. So at grade 3, we usually shift the patient to ICU and manage the grade 3 CRS in ICU. So if the patient is requiring multiple inotropic support or requiring BiPAP or intubation or mechanical ventilation, then it becomes a grade 4 CRS. So how do we monitor? We monitor by doing interleukin 6, by doing these markers interleukin 1, interferon gamma, ferritin, CRP, and in certain cases when we want to differentiate or assure the patient to rule out hemophagocytic syndrome, then this is something called a soluble CD25, which is available and can be sent to differentiate between hemophagocytic syndrome and CRS. So now you all can take this quiz. I'm sorry, the previous one. I don't know. So we can just ask someone, if someone can just say this. What is the cytokine release syndrome commonly associated with? Which therapy? Is it chemotherapy, immunotherapy, radiation therapy, or surgery? It's a very simple question. Please raise your hand and answer. Nobody knows, इतना बड़ा lecture के बाद भी, nobody knows what is it associated with. Please unmute yourself and just say which therapy is it associated with. Something in the chat, immuno, yes. So, okay, let's move ahead. think कोई फायदा नहीं हुआ lecture का. Okay. Now, which cytokine is most commonly elevated in CRS? Please tell me. अभी मैं इन सब का नाम लेती हूँ. अरे वाह. Dr. Sneha is the most intelligent amongst you all. So, क्या कर रहे हो सब लोग? Very good. Which cell therapy is known to cause? 1 minute, I get a call. So, ये तो बता दो. अरे, Dr. Laika, which cell therapy is associated with CRS?
Hello.
Which cell therapy is associated with CRS? Gene therapy, platelet transfusion, CAR-T.
Party.
Very nice. Thank you. So, and which treatment is often used amongst this? Abhi to we will cover on the treatment, but what do you think will be most commonly used? Antibiotics, antiviral, antifungal, or corticosteroids?
Corticosteroids.
Yes, very good. So, and one of the most common symptom is? Which is the most common symptom amongst all this headache, nausea, rash, or what did we?
Fever.
Yes, yes, very good. So fever is the most common symptom. Very nice. So who's Dr. Pooja? Wow, congratulations, Dr. Pooja. You won all 5, correct? Very nice. Chalo. I hope you liked the session, and we'll continue with the management next time. Thank you everyone for joining.
Okay, ma'am. Thank you.